You have heard from the previous speaker that you always should think on the posterior pelvic ring if you treat the anterior pelvic ring. Same is true opposite. If you fix the posterior pelvic ring, you should always think, what do I have to do in the anterior pelvic ring? Because the goal is to close the pelvic ring, to restore a ring, and not only a partial restoration is good. It must be done anteriorly and posteriorly, depending on the type of injury. So we do not fix the posterior pelvic ring with an open reduction and internal fixation, or even a percutaneous fixation, in the resuscitation phase of the patient. So not on day one. That's our, let's say, that's the rule. There are exceptions, but only very few. The current procedure in our hands is a ventral external fixator. You know that we apply the pelvic binder, pelvic sheet during transport. It can remain for a day, but not longer because of the soft tissues. So the current procedure would be the external fixator, and in exceptional cases, the C-clamping. You have heard that before in exsanguinating patients. What are the prerequisites for an open reduction internal fixation of the posterior pelvis? First of all, the patient must be hemodynamically stable, blood clotting normal, the operation team well prepared, because we can face complications and we have to deal with them. We have to be able to deal with them, which means that we have to plan our surgery very well, and we have to take CT scans and reconstructions and look at them, and then decide on beforehand what we do with the instability and the posterior pelvic ring. We have anterior approaches for the posterior pelvic ring, posterior approaches, and percutaneous approaches. First, the anterior approach. What are the indications? The pure dislocation of the sacroiliac joint, the fracture dislocation. You have seen nice pictures of crescent fractures, and transiliac instabilities. That means fractures that go through the ilium, iliac wing, and crest. The technique is an incision along the iliac crest. I will show that. We have to take care of the nerve roots L5 and S1, which run very near to the sacroiliac joint. And we, as we treat adults, we will use large implants to fix the sacroiliac joint. So the patient is in the supine position. You see here the right hemipelvis, and your incision is not on top of the iliac crest. It's just a little bit lateral to the iliac crest, because you want to take the abdominal muscles from lateral to medial, so deperiostation, and you don't cut the abdominal muscles away from the iliac crest. No, you take them with the periosteum together from lateral to medial. It does not bleed at all. If you take the incision here, you cut through the muscle and it's bleeding all the way. So then you are on the edge, and then you do a deperiostation of the inside of the iliac wing, and that's here. So the abdominal muscles are taken together with the iliacus muscle, which is on the medial part of the iliac wing, and here you go down until the bottom of the iliac wing, and normally if you have a pure dislocation of the sacroiliac joint, you will find this disruption. The anterior ligaments are disrupted, and there is a diastasis of 1 or several centimeters with blood inside. Then now you can place Hohmann retractors. You see that here. I do not use that. I prefer to use Kirschner wires with 1.6 millimeter diameter. Just I hammer them in on the lateral side of the sacrum, because this is for me too heavy, and there is a higher risk of damaging the nerves, and it's also more difficult to put them inside the bone, because the tip is not very sharp. Then you can open the sacroiliac joint. You see here a bone spreader is used inside to clean the joint. Sometimes particles of cartilage or also blood clots are inside. That's normal. So that you see very nicely inside the joint, the medial part, the lateral part, and everything is clear and empty. And then you can, with the help of a pusher or with the help of a T-handle, you can reduce the iliac wing towards the sacrum. Here the relationship between L5 and S1 to the lateral margin of the sacrum means the sacroiliac joint. In the proximal part it's about 2 centimeters. The distal part it may be less than 2 centimeters. So if you put a plate on this, it really can hurt the nerve, especially if you put a plate with the edge pushing on the nerve. It can give you a continuous pain in the leg. Here is 2 methods of reduction of the dislocation. Here a T-handle, also manual pressure on the iliac wing will help to reduce it. And here you see a Farabeuf clamp with 2 large fragment screws placed above on the upper part of the sacroiliac joint. What we prefer is a large plate, as I said, and a spongiosa screw in the sacrum because we have spongiose bone, and a cortical screw in the ilium, or 2 cortical screws as mentioned here in the ilium, because there we have strong cortical bone for a good buttressing. You take 2 plates that are 60 to 90 degrees to each other. They have to be pre-bent along in accordance to the anatomy of the patients you have there. This is different in male as in female. So take care of that, because if you do not pre-bend well, you will dislocate the reduction of the sacroiliac joint by tightening your screws. Here is the example of a child that was overridden by a car. You see a bilateral sacroiliac dislocation, a pure dislocation. You see this external fixator on place in the resuscitation phase, and then after 1 day we did a bilateral sacroiliac joint reduction and fixation with plates from the front. And the external fixator was left in place for the anterior instability. Here you see the inlet and outlet views. Here a transiliac instability with the dislocation of the symphysis pubis, the 3-dimensional reconstructions. And here you see a plating done and a lag screw from the inside of the iliac wing together with a small plate on the iliac crest and a bridging plate fixation of the symphysis pubis, and these are inlet and outlet views. It looks simple, it's not that simple. Here you see a recent publication from a Chinese group, 29 patients, 30 sites were operated, but you see here excellent reduction in 77, it's not 100%, good in 6, it's 20%, and fair in 1. But you see here the wear injuries of the lumbosacral trunk in 10% of the cases in 3 patients, and femoral cutaneous nerve in 7, which is 23% of the cases. So you have to take care of the soft tissues, especially of the nerves, if you do this surgery. Posterior approach, which are the indications, the best indications are the sacral fractures. The dislocations can also be treated from behind. Fracture dislocations, I would never do the transiliac instability from behind, because you have to detach the gluteal muscles from the iliac wing, and this will give you muscle weakness. So bad walking, it's much better to do that from the inside, but theoretically you could do it from outside as well. Alternatives are screw osteosynthesis, which is the rule in our house. So trans-iliosacral or a bridging plate or even sacral bar osteosynthesis. For the screw osteosynthesis, we take the patient in the prone position. with an image intensification that enables good views of the pelvis, of the dorsal pelvis, the inlet, the outlet, and the AP view. And that's what you see here. The position of the patient, inlet, outlet, AP, and these are the different views that you have of on your image intensifier. And there you have to look at the landmarks, the neuroforamina, the promontorium, the anterior cortex of the sacrum, the sacral canal, and here the same in the inlet view. And then you have to look at the corridor, the sacral corridor that fits for 1 or 2 screws in S1 or in S2. Which technique do we use? If we do it open, we will perform an incision lateral to the posterior superior iliac spine. We mobilize the gluteus muscle, the gluteus maximus muscle, the erector spinae muscle, and the multifidi muscles. These are muscles of the spine. These are muscles of the pelvic girdle. And then we are able to look at the joint and also at the posterior surface of the sacrum. And if we flip up the spine muscles, they remain in good condition and they are not in necrosis. And we mobilize the piriformis muscle. We can go with the finger in the sciatic notch and feel on the frontal side if the reduction of our dislocation is correct. Here you see that. That's the gluteus maximus that is attached partially to the sacrum as well. Here is the gluteus maximus. This is the multifidus muscle and erector spinae. You see it here. Some parts of the dorsal ilium. Here the sacroiliac joint, and that are the neuroforamina, with here, in this example, a fracture to the sacrum, and the possibility of touching the anterior part of the sacroiliac joint with your finger. As I said, we have to rely on images of the image intensification, so your patient has to be prepared, the bowel has to be empty as much as possible, therefore you need some days sometimes, but it's important. You cannot drill a screw in a, let's say, in a region that you cannot look at, because there are too much structures that can be in danger. There are vessels, there are nerves, there is the sacral canal, so if you misplace, you can face different severe complications. What we do is to place 2 long cancelled screws in case of the pure dislocation or in case of a lateral fracture of the sacrum in the body of S1. We know that it is more stable to put 2 screws than only 1 screw. A long thread in case of lateral lesions or the dislocation, a short thread if the fracture is in transforaminal or in the body of S1. Take care of the different structures that can be hurted. Here you see intraoperative views of such a procedure, and you recognize very well promontorium, S1, S1. So the drill is inside the body of S1, the same here in the inlet view and in the outlet view, so you are sure that your screw is placed correctly, and that's the second screw that is placed, and you see the tip of reduction forceps of this dislocated joint. Here an example of a motorcycle driver, a pure dislocation on one side, a transforaminal fracture on the other side, and a dislocation of the symphysis pubis. A bilateral double screw osteosynthesis has been done, and that's the situation 1 year later when the patient came back for removal of the implants. Here, a working accident. A patient got a very heavy load on his back. You see a pure dislocation on one side, a fracture dislocation on the other side with a crescent fracture, but also a crush region, intraperitoneal bladder rupture. You see it here, primary fixation with an external fixator. Some days later, we did bilateral reduction. You see here for the crescent fracture, a lag screw was put in additionally, and then 2 screws in the body of S1 on both sides. That's later on after removal of the external fixator. When do we use sacral bars and bridging plates? Well, we use it in our house very seldom, only in bilateral or multifragmentary sacral fractures, which goes in the direction of the spinopelvic dissociations, which is another entity, and for that, sometimes you need spinopelvic constructions, not only sacral bars. The characteristics are that the implants are inserted behind the sacrum, so there are no neural elements at risk, but it's bulky, and sometimes the patient, when they recover, they feel these elements when sitting on The technique here, you make 2 incisions lateral to the posterior superior iliac spine, and then you make a corridor between these 2 incisions behind the sacrum, and the implants are placed and fixed to the dorsal ilium. Here you see the case of sacral bar osteosynthesis. You can recognize that the incisions. They can be much smaller, but you recognize the region of the incisions. That's, in this case, the fracture. That it can be a bilateral lesion. And here, the end result when you have placed 2 bars behind the sacrum. The other construction that I like more is to place a bended plate below the posterior inferior iliac spine on both sides, a bended plate so that you can use 2 screws in the ilium that are very large. Here you see a example of sacral bar osteosynthesis, and here you see an example. Both patients were suicide jumpers, a multifragmentary sacral fracture again, with an acetabular lesion, and you see the plate that is bended behind the sacrum. It's in combination with sacroiliac screws, but if you look at the length of the screws that go into the ilium, it's very long, one in the frontal and one in the cranial direction, and they give a very good stability of the dorsal pelvic ring. What we see now, and we have another talk on this in a moment, is more and more insufficiency fractures in older people, fragility fractures of the pelvis in severe osteoporosis. Here you see such a patient with an injury at the pelvic ring, very near to the sacroiliac joint, and we use more and more angle stable plates. That means internal fixators, I would say, to fix these fractures, because they have a better holding power than the conventional plates that we use for pelvic fractures in adults. So I think that if you start this surgery, you have to look at your CT scans and reconstructions before you do that. You have to look at different surgical alternatives. Go I from behind, go I from the front. What are the possibilities and the drawbacks of my techniques? And therefore the surgeon should be familiar with all the techniques to be able to choose the optimal solution in each fracture configuration. Thank you very much.
Very much, Professor Rommens. Professor Abdel will speak about fracture of the sacrum, the spinal pelvic.